So I think we'll get underway. Can you hear me? Is this mic on? Yes. Okay. Great. My name is Ollie Fine. Going to be chairing the meeting this afternoon because both Kurt Cole and Beth are actively working elsewhere. Again, if you haven't signed up, please sign in so that we can, in fact, know how many lunches to order in the future. So, this is a very special event because it is co-sponsored today by a group called the Heberden Society. The Heberden Society is a group very interested in the history of medicine and tends to meet separately from the Rogers Colloquium. But frankly, Nicole Milano, who is the archivist here, decided that this was a real opportunity this year to try to bring together both the Rogers Colloquium and the Heberden Society. So to do our introductions, however, I'm going to ask Anna Vaith to come up. She is a third-year student, and she is going to be introducing our speaker. Come to the podium and take over.
Thank you so much. Hi, everyone. My name is Anna Vaith, and I am one of the two student representatives of the Heberden Society. Just some background on the Heberden Society. We like to promote interest in the history of medicine at Cornell, and this is the first of our 4 lecture series throughout the year with the Rogers Colloquium. All right, so there is a persistent stereotype that immigrants are carriers of sickness. Join Beatrix Hoffman as she pushes against that stereotype, focusing instead on how the health of immigrants is harmed after they arrive in the United States. In addition to sharing historical examples of how workplace and immigration policies are a menace to the health of people who immigrate, she will also demonstrate that far from threatening public health, immigrants have made significant contributions to improving health and healthcare in the United States. Beatrix Hoffman is a historian of the United States healthcare system and Board of Trustees professor at Northern Illinois University. She earned her PhD from Rutgers University, and her new book, Borders of Care, Immigrants, Migrants, and the Fight for Healthcare in the United States, will be published in January 2025 by the University of Chicago Press. Please join us in giving a warm welcome to Dr. Hoffman.
Thank you so much, Anna and Dr. Fine. And I'm really excited to be here. I'm always so impressed, and I love talking to groups of medical students about history of medicine, and just admire you for having such a range of interests that will make you excellent practitioners. To have an awareness of historical context of medical care and social and political context is just a fantastic thing for you to be doing. And I would like to just quickly thank also Paul Howell and Nicole Milano, who originally set this up, but especially Sana Masood, who's been a wonderful host and also rescued me when from near disaster when I left my laptop on the subway yesterday, and I was able to retrieve my talk and have Sana print it out. So here it is. And I've also been warned about the MRI, which I believe that's what that little beeping sound is. How is my volume? Is this okay? Okay, wonderful. So as Anna mentioned, I recently completed a book called Borders of Care, which is a history of access to healthcare for immigrants and migrants in the U.S. And my talk today is actually not taken directly from the book, but it's something I realized I needed to think about after I finished writing the book. So in Borders of Care, I argue that contrary to a lot of the political rhetoric that we're hearing now and always, immigrants have not been burdens on the U.S. health system, and that, in fact, immigrants and immigration have served to improve U.S. healthcare in significant ways. And this afternoon, I want to make a related but somewhat different argument. So I'm going to take this opportunity to talk about what I have learned from my research and also from the incredible historical literature on immigration and disease in order to question the stereotype that immigrants are carriers of sickness. Quite the opposite of immigrants being seen as a threat to the nation's health, I will focus on how U.S. labor and immigration policies are a menace to the health of people who immigrate. So historians have been working to debunk the notion of the immigrant menace for at least 30 years. In his 1994 book, Silent Travelers, Alan Kraut demonstrated that panics about Irish, Chinese, and Southern and Eastern European immigrants bringing disease were rooted in eugenics and xenophobia. And this influential book has the term immigrant menace in quotes on the cover, inspiring my title today. Since Silent Travelers, other scholars have deepened the analysis and expanded it to look at how Irish, Mexicans, and Chinese immigrants have been stigmatized as carriers of typhoid, plague, tuberculosis, and other maladies, leading to harsh discrimination, detention, and exclusion. And there are additional important books than the ones I pictured here. I'm going to be calling out a lot of my fellow historians in this talk. This phenomenon was summed up by Howard Markel and Alexandra Stern in 2002 as the persistent association of immigrants and disease. And persistent it has been. So I'm going to read some of these current quotes to you. The trope of the immigrant menace to health, as we all unfortunately know, is alive and well in U.S. political discourse today. So most recently, we had Vance talking about Springfield, Ohio, in addition to the other slanders that he keeps repeating. He talked about immigrants also bringing disease, Haitians bringing disease. And recent quotes going back to 2015 from Republican politicians repeating this trope over and over again, the immigrant threat to health. But I do want to point out that the persistent association of immigrants with disease is not confined to the far right or even to anti-immigrant movements. During the battle over Proposition 187 in 1994, which would have denied public education and non-emergency health care to undocumented immigrants, California Democrats and liberal groups relied on the immigrant menace to health as one of their arguments against the proposition, stating that without access to health services, immigrant workers could spread disease unchecked. So this quotation, which is taken from the longer document on the left, makes a political point by emphasizing that denying medical care to immigrants would be a threat to the health of the general public, since many of them handled the food supply.
What's the matter with that?
The immigrant menace also underlay Title 42, the public health law repurposed as an immigration control member by Trump strategist Stephen Miller, but also continued for 2 years by the Biden administration. Title 42, which allowed migrants to be barred or expelled as part of the public health emergency that ended in 2023, is actually an immigration restriction masquerading as a public health measure. But like the quotations on the previous slide, it shows that the association of immigration and disease still plays a really major role in U.S. discourses and policies. So we've had years of scholarship on immigration and health to break this connection and show the social construction of the association between immigration and disease. Yet here we still are. So what I want to emphasize today is not how the stereotype is false, although it is false, but the ways in which the opposite is true. Being an immigrant has been and is a risk factor for harm to health. And this is due to structural factors that are policy choices by the United States. In this so-called nation of immigrants, U.S. labor and immigration policies have been and are a menace to those who seek new lives here. I'm far from the first scholar to make this point, and in this talk, I will be pulling together research from immigration history, labor history, and also public health to focus on the menace to immigrants, which is critically important if we are truly to interrogate and interrupt the persistent association of newcomers with disease. So I'm going to focus on two of the major historical and structural factors that menace immigrant health. And by structural, I mean these are features that are built into U.S. labor, health, and immigration systems and policies. The first one is working conditions, and the second is the U.S. regime of immigration control and enforcement. In 1987, David Rosner and Gerald Markowitz wrote that the exploitation of labor is measured not only in long hours of work and in lost dollars, but also in shortened lives, high disease rates, and painful injuries. And in the subtitle of a recent article, Alan Derrickson calls attention to the inordinate exposure of immigrant workers to occupational health hazards. The insights of these historians and others invite us to ask how labor exploitation intersects with immigration status and how this affects health. So I'm going to take a really quick chronological tour through some examples of this. The mercury mine at New Almaden in Northern California opened in 1847 and became a booming business due to the gold rush, since mercury was used for extracting precious metals from rock. As the business expanded, its owners were able to take advantage of a glut of immigrant workers from Mexico and South America who had been excluded from gold mining by California's tax on foreign miners. Miners were exposed to injury and death from cave-ins, explosions, and accidents. Above ground, mercury poisoning plagued workers at the reduction furnaces where they sorted and roasted the cinnabar ore and inhaled quicksilver fumes. And company records show that Mexican workers had a much higher rate of fatalities in the mine, nearly 4 times greater than did Anglo-American workers. While only 8.5 whites per 1,000 died at New Almaden, Mexicans suffered from a death rate of 30.5 per 1,000. This was not just due to being given the most dangerous jobs underground. The company town segregated Mexican and Chilean workers into a settlement known as Spanish Town. Spanish Town was directly downwind from the fumes spewed out by the mine's furnace, literally placing workers and their families in harm's way. In Arizona's copper mines, both Mexican-American and Mexican immigrant workers received a lower Mexican wage, as it was called, and these workers suffered higher rates of tuberculosis and other respiratory diseases, as well as mining accidents, than did the higher-waged Anglo workers. Fatalities were so common that the Mexican consul in Phoenix received constant requests to help the families of dead miners return to Mexico. When Mexican workers organized into mutual aid societies and labor unions, among their major demands were improved health and safety conditions and also free hospitalization and life insurance, which tells us that the menace to their health and lives was at the forefront of their concerns. As these examples show, occupational segregation and racial discrimination created a health menace to immigrant workers. Where hospital care was provided, as in the Western Railroad industry in the 19th century, Chinese workers were officially excluded from company hospitals and medical care. Chinese laborers on the railroad also earned as little as half the wages that European workers received. And like Mexicans, they were frequently given the most dangerous and deadly jobs. During the Progressive Era, when physician and Hull House reformer Alice Hamilton studied hundreds of cases of lead poisoning among industrial workers in the Midwest, she found that they were almost always foreigners. She reported that immigrants, especially those who did not speak English, were deliberately given the most hazardous jobs and could not understand what little safety information was provided due to the language barrier. And this 1960 pamphlet on the right for newly arrived Jewish immigrants shows an awareness of how housing and employment conditions could menace their health. The author warned that immigrants are apt to suffer greatly. They meet with accidents because our civilization depends far more upon machinery than that to which they've been used. When they live crowded together, as they do in our tenement houses and in the shanties of a camp, their vitality is lowered, and they become ready subjects to such diseases as pneumonia and, what is far worse, consumption or tuberculosis. A great many immigrants who have been strong and well on their arrival in this country have died from tuberculosis within 3 years of their coming. Exposure to respiratory disease in housing, mines, and factories may also have left immigrants more vulnerable to sickness and mortality in the influenza pandemic of 1918 to 19. Some evidence points to influenza as a menace to immigrant workers disproportionately. This 1927 study by public health researcher E.O. Jordan, he didn't look specifically at immigration status, but he does show that influenza deaths were the highest among the lowest income industrial workers. Using insurance company death tables, Jordan found a definite relation between low income and influenza mortality. And we know that at this time, the lowest income workers were disproportionately immigrants. And the first, and I think is still the only memorial to the influenza pandemic in the US, this was only erected in 2018. This is in Barre, Vermont. And this image, this memorial, points to immigrant workers as especially susceptible to the flu. So this person depicted here, Brian Zetchinelli, is a town resident who commissioned the memorial, learned that his grandfather and dozens of his colleagues perished because he worked in a poorly ventilated granite factory where he and others breathed in vast amounts of dust which left them vulnerable to influenza. And more than 100 granite workers in Barre died in the span of 3 weeks in 1918, nearly all of them Italian immigrants. And a recent article by Maria Losa describes how influenza was especially hazardous for Mexican migrant worker families in the sugar beet industry who lived packed tightly together in company housing. And she found that some Mexican workers in the fall of 1918, at the height of the pandemic, even skipped out on their contracts to avoid getting sick with the flu. And this is another example of migrants' awareness of the conditions that menaced their health. A study of high tuberculosis mortality among Mexicans in Chicago in the 1920s noted that among the severely ill TB patients at Cook County Hospital, practically all of the Mexicans were unskilled laborers again. And the Mexican men who made up this low-wage workforce in the railroad, stockyard, and steel industries and their families, the study reported, lived in boxcars and colonies that make it difficult to escape infection. And this is one of the boxcar homes depicted on the left here. In the railroad boxcars, they have no light, ventilation, running water, or toilets. And the picture on the right also depicts industrial workers housing in an urban setting. But the study concluded that the solution was not higher wages or better housing, but rather immigration restriction to keep out allegedly diseased Mexicans, thus contradicting its own data about how migrant sickness was actually acquired in Chicago. As the historian Emily Abel puts it, public health leaders continued to depict Mexicans as agents of disease rather than its victims, despite abundant evidence to the contrary. One of the most famous images here of the idea of the immigrant menace, this is of braceros, Mexican contract workers, being sprayed with pesticides on entering the US. It's clear in this 1956 photo that the man doing the spraying is masked. So they were aware of the hazard, but the workers were not provided with masks. And in this practice of fumigation at the border, we see an example of how the mostly false stigma of infectious typhus, a lice-borne disease that attached to Mexican workers, led to an actual menace to their health: exposure to dangerous pesticides. Contract workers in the Bracero program were required to arrive at their agricultural jobs healthy, but many of them ended up getting sick or injured in the US. Braceros were injured or killed in work accidents and frequently automobile and truck crashes. Crowded housing, again, forced workers into close proximity and created breeding grounds for TB and other respiratory diseases. Bracero contracts required employers to provide workers with food, but often the quality was horrible and led to malnutrition, intestinal parasites, and outbreaks of food poisoning. In the fields, laborers became sick from heat, dehydration, exposure, pesticides, again, and exhaustion. And workers, again, showed an explicit awareness of the menace to their health. One bracero told his story to a congressional hearing in 1958. He reported, "Around November 1, I got pneumonia from getting wet while working. I was sick for 22 days. The whole time I had to keep paying for my board out of my own pocket. The insurance that was taken out of his paycheck paid nothing. Finally, on November 20th, my contract expired, and I was sent back to Mexico, although I was still sick." His story illustrates the observation of several scholars that the deportability of Mexican workers enhanced their desirability to employers who could exploit them in times of labor shortage, but then remove them when they were no longer needed or when they needed medical care. The Bracero program ended in 1964. And 1 year later, the United Farm Workers conducted their first strike in Delano, California. And many of the UFW's subsequent campaigns would focus on the menace to health experienced by both immigrant and citizen farm workers. This pamphlet points out that farm work is a risk factor for lower life expectancy. And such messaging was used for fundraising for opening the UFW's own medical clinic in Delano for farm workers. And they also ran many campaigns against pesticides. The danger was no longer from fumigation at the border, but from exposure to substances sprayed in heavy amounts on their workplaces. Cesar Chavez argued many times that pesticides should be called economic poisons. And with this phrase, he directly critiqued the health menace to farm workers and linked it to their structural position in the US workforce. Today, immigrants make up a far larger percentage of the farm labor force than they did in the UFW's heyday. Nearly 3/4 of all workers in US fields are immigrants or migrants. And farm work continues to be among the most dangerous of occupations, with a fatality rate 5 times that of all other workers. They continue to lack access to adequate sanitation, safe housing, and medical care, and have disproportionately high rates of preventable illness. The anthropologist Seth Holmes writes of migrant farm workers that as a result of their dedication to the US agricultural fields, their bodies ache, decay, and are injured. And during the COVID pandemic, farm workers were designated essential and experienced high rates of infection and death. Another industry with a majority immigrant workforce is food processing. And we can see the menace to immigrant worker health most starkly in this incident that I'm going to describe from the first wave of the COVID pandemic in early April 2020. COVID broke out among the workers at a Smithfield pork processing plant in Sioux Falls, South Dakota. Many of us may remember this. County health officials moved to shut down the facility, but Agricultural Secretary Sonny Perdue jumped in. And if that name sounds familiar, he, yes, is the scion of the Perdue chicken family, who was appointed Secretary of Agriculture by Trump. Perdue wanted state health authorities to reopen the plants. And he sent this urgent email to the South Dakota governor And this is somebody who's also been in the news recently for a different reason. Governor Kristi Noem of South Dakota. She's now famous for apparently shooting dogs, but wait till you hear what she did in the pandemic. So Purdue wrote to Noem that of the urgent need to keep these meat packing plants, meat processing plants open, despite the fact that COVID was raging through them. And 2 weeks later, Trump signed an executive order to declare meatpacking plants as critical infrastructure. The South Dakota plant reopened, and in the weeks following, more than 1,200 employees at this single facility tested positive for COVID, and at least 4 died. In 2020, about 350 meatpacking workers in the US died of COVID, but the plants stayed open. And this image shows a grieving family drawing attention to how their loved one died because they had to go to work without adequate protections. So just these few years ago, it was nothing new that immigrant workers were put in harm's way, as we've seen. But in 2020, the calculus was on full display. By government decree, these workers were both essential and expendable. So the second theme is immigration control. There's an example that US historians use a lot when we teach the survey. At least I always use, of Ellis Island. So when people arrived at Ellis Island around the turn of the century, they had to go through a medical inspection. And there's a famous example of how immigrants had to undergo an eye exam to search for trachoma. And the examiners would use like a crochet hook or a button hook to flip back the eyelid. And famously, they would not then sterilize the button hook. So this is a great story to gross out my students. Always seems to work to do so. But it also it illustrates the point that immigration control and enforcement can spread disease rather than stopping it. Inspection, disinfection, quarantine, deportation or repatriation, and border control and detention all pose and have historically posed particular menaces to immigrants' health. We can find early examples in the case of the quarantine of newcomers, the involuntary conditions of confinement and crowding that made immigrants sick. For example, in 1848, a typhus outbreak killed a significant number of detainees at the quarantine facility in Staten Island, where the Ellis Island arrivals were held. Historians Erica Lee and Nayan Shah provide examples of how quarantine detention at Angel Island in San Francisco, which was used far more extensively than at Ellis Island, could lead to previously healthy Asian immigrants and travelers getting sick. Shah writes that many Chinese immigrants fundamentally doubted that they carried sickness in their bodies and instead presumed that the process of detention produced illness. Angel Island detainees who got sick during their confinement complained about the conditions, hired lawyers to petition for their release, and even wrote poetry about the dangers to their bodies in quarantine. And I believe some of these can still be seen if you visit the Angel Island Historical Site today. This was graffiti poetry that detainees wrote on the walls. In this newly open wild land, the environment is not agreeable. Drinking water, many develop coughs. Sipping it, not so few develop sore throats. 100 symptoms of sickness developed. It is difficult to put our misery into words. The historians Natalia Molina and Emily Abel have described how notions of Mexican immigrants and Mexican Americans as diseased underpinned the mass deportations and repatriations during the Great Depression, when up to 1 million people of Mexican origin, including US citizens, were forced to leave the country. But mass deportation also caused damage to health. Many of those repatriated were already sick, elderly, or babies. According to Francisco Valderrama and Raymond Rodriguez's extensive study, Deaths occurred daily along the way and in repatriation centers at the border. Too often, the forced repatriation of individuals not fit to travel became a virtual death sentence. A Mexican newspaper reported that on board one repatriation train, 25 children and adults had died of illness and malnutrition during the trip to the border. And the New York Times published a story about 26 repatriated people who were left in Ciudad Juarez and then died of pneumonia and exposure. 2 decades later, the Eisenhower-era deportation campaign with the horrible and derogatory name of Operation Wetback also endangered the health and lives of migrants who were targeted. In a practice known as the hot foot lift, U.S. immigration agents dropped deportees in the middle of the desert, deliberately hauling them to a place where there is no food, water, or shelter. Newspapers reported that Mexican border towns, swelled by the arrival of thousands who had either been apprehended and sent there or who had fled across the border to avoid capture, were without food or shelter. To prevent deportees from quickly returning, U.S. immigration officials conducted a boat lift to take them halfway down the Gulf Coast of Mexico, and several men on one of these boats jumped overboard to protest the severe overcrowding, and 4 of them drowned. When immigrants are targeted for deportation today, there can be serious health consequences. Public health scholar William Lopez studied the aftermath of a 2013 deportation sweep by Immigration and Customs Enforcement, ICE, in rural Michigan. After raiding a workshop and detaining the men who worked there, ICE and a local SWAT team conducted a no-knock raid on an apartment housing mothers, teenagers, and small children. Armed and armored agents broke down the door, stormed in, and forced everyone, including the children, to the floor at gunpoint. All the men at the workshop, as well as an 18-year-old at the apartment, were deported, and their family members left behind to pick up the pieces. The women and children who underwent the apartment raid suffered shock, post-traumatic stress syndrome, and thoughts of suicide. A young mother with a 3-month-old baby was no longer able to nurse her child, explaining that her milk didn't work anymore. As Lopez writes, the physical trauma of the raid increased the reach of ICE into the women's futures and those of their children. Other scholars have found a correlation between immigration raids in a community and the negative health outcome of lower infant birth weights. The anthropologist Leo Chavez writes that the fear of deportation can be just as devastating as deportation itself, leading to self-monitoring behavior such as avoiding medical appointments, not seeking help from police, or staying at home and avoiding dangerous public spaces, even going to the grocery store. Children who constantly think about the possibility of their parents' deportation experience clinical levels of separation anxiety. In interviews conducted by the public health researcher Luis H. Zayas, children of undocumented parents talked of recurrent nightmares of chase, capture, and families torn apart. Deportation is a feature not just of U.S. immigration policy, but also of its health policy. In a practice known as medical repatriation, hospitals eject immigrant patients suffering from long-term life-threatening health conditions and send them back to their home countries, sometimes with their permission or that of their families, but often against their will. In one example, the case of a Mexican worker who was comatose after a workplace accident in Chicago, hospital staff disconnected him from equipment and rolled him away on a gurney as one of his caregivers pleaded for them to stop. He was then loaded onto an air ambulance and flown to a hospital in Oaxaca, where he died a year later. This 2012 report found over 600 cases of hospital deportations in the U.S. over a 5-year period, concluding that the practice was widespread but barely publicized. Medical repatriations are unregulated and usually unreported, and hospitals justify them as a cost control measure. Cost was the reason given when in 2009, Grady Hospital, a large public hospital in Atlanta, Georgia, shut down its free dialysis clinic. Its clients included dozens of undocumented immigrants. After public protests, Grady came up with an offer for the undocumented patients 3 months of treatment at a private clinic, and then airfare to their home countries. Some of the patients found a lawyer and filed a human rights complaint. And they actually ended up being able to stay. But some took the repatriation deal. An investigation found that of the 10 to 13 patients who relocated to their home countries, many faced difficulty obtaining dialysis, and 2 of them died. It's important to specify how U.S. law creates categories that put people in harm's way. The Hart-Celler Immigration Act of 1965 ostensibly ended racial national quotas, but at the same time, it forced millions of Mexican and Latin American migrants into undocumented status by creating quotas for their admission for the first time. Congressional action that escalated border enforcement in the 80s and 90s further increased the undocumented population by closing off avenues for people to return home or to move back and forth. And the building and hardening of walls and fences made the border crossing journey more dangerous, even as U.S. demand for undocumented workers' labor continued unabated. The act of migration itself has become increasingly dangerous to health and even to life. Clandestine border crossings expose migrants to accidents, drowning, dehydration, and deadly heat. Between 1998 and 2018, at least 7,500 people died in attempts to cross the U.S.-Mexico border. And migrants confronted by the U.S. Border Patrol are also vulnerable to physical danger stemming from what Human Rights Watch called the dehumanization of undocumented immigrants, which permeates these enforcement agencies. For example, a witness at a 1993 congressional investigation of border violence reported that some Border Patrol agents called migrants by the nickname tonks for the sound made when hitting them on the head with a flashlight. There are also health consequences when states attempt to escalate immigration enforcement through laws that curtail immigrants' access to health and welfare services. In 1994, California voters passed Proposition 187, which would have ended undocumented people's access to public education and non-emergency public health services, and would require teachers and healthcare workers to report people's immigration status. Even though this proposition was eventually struck down by a judge, the contentious debate had a negative effect on immigrants' health, including legal immigrants who feared racial profiling. Los Angeles County announced that their health facilities had experienced a 20% drop in prenatal care visits between September 1993 and September 1994, even before the law passed. And there was additional evidence that Proposition 187 was deterring people from using needed medical services or leading them to be denied services. A young boy with leukemia died when his family skipped a hospital visit, fearing detection by immigration authorities. An elderly woman in San Francisco died of a brain hemorrhage because she was afraid of being deported if she sought treatment. Some pharmacies, dental clinics, and hospitals began demanding immigration papers, even though Prop 187 was being challenged in court. In addition to local initiatives, federal laws such as the 1996 welfare reform that banned legal immigrants from Medicaid for 5 years after they arrived had a chilling effect on people's willingness and ability to obtain medical care and coverage, even care to which they are entitled by law. For example, immigrant parents' enrollment of their citizen children in Medicaid dropped significantly, both after Proposition 187 and after the passage of the Clinton welfare reform. The final aspect of immigration enforcement I'm going to discuss is detention. In fiscal year 2021, the U.S. held 250,000 migrants in 200 facilities around the country. This is 20 times the number that were detained in the 1970s. In the past 50 years, and especially since the start of the 21st century, the U.S. immigration detention system has grown to be the largest on Earth. And scholars have begun to write powerful histories of immigrant detention. If you want details on these books, I can give them to you later on. They show how the expansion of the system dates to the Cuban and Haitian refugee crisis of the late 1970s, when the government decided to treat Haitians in particular more like criminals than like asylum seekers. The targeting of Black refugees intensified in the 1990s with the opening of a processing center in Guantanamo Bay, Cuba, intended to prevent Haitians from even reaching the U.S. mainland. One slide out of order here. Here we go. Remind me to go back. Scholars also find a history of protest and resistance to the detention regime by immigrants and refugees and their allies. And these protests have often focused on medical care and health conditions. So this is an organization that summarized reports of abuse and neglect in detention centers and found that medical issues, so this is the tallest bar on the left here, those were at the top of the list. And medical conditions have been a recurrent theme of detainee protests. At the El Centro Detention Center in California's Imperial Valley, where migrants conducted hunger strikes in the early 1980s, one of their complaints was that the only treatment available for injuries and illnesses was aspirin. Human rights groups reported that medical neglect was a problem at detention facilities around the country. In 1990, the American Friends Service Committee reported that a common problem at centers in New Mexico, Texas, and Florida was the lack of medical attention for detainees, all reported poor sanitary conditions. At a detention center in South Texas, migrant women complained of a lack of hygiene and of not being allowed to bathe or change uniforms more than every 8 to 20 days. At this center, there was also a waiting list of up to 2 weeks to see a doctor. One pregnant woman had a high fever and bleeding, and by the time she received medical attention, she had already miscarried. Another human rights group found widespread unhygienic conditions, poor or absent medical care, and the inappropriate use of medication, including sedatives, at immigrant detention centers. Christina Scholl, historian, writes that in detention centers, medical and health emergencies, here's where this slide should be, sorry. Yay. Medical and health emergencies go untreated but become opportunities to seclude and punish. And this was starkly the case at the Guantanamo detention facility, which in the early 90s began holding HIV-positive Haitian refugees in quarantine in extremely harsh conditions and without adequate medical care. Haitians detained at Guantanamo organized a protest movement, pictured here, that drew support from the AIDS rights organization ACT UP and U.S. racial justice groups. Their protests finally led to a judge's decision in 1993 to free them from what he called an HIV prison camp that posed severe risks to the detainees. In the COVID pandemic, immigrant detention centers, along with other carceral institutions, became super spreaders of infection. At one facility in Arizona that failed to provide basic protective equipment to detain people, did not require guards to wear masks, and did not enforce social distancing, over 700 migrants were infected. And when detainees organized peaceful protests to demand COVID protections, they were sprayed with chemical agents and placed into solitary confinement. A significant number of immigrants were infected with COVID in detention centers and then deported, spreading the disease on airplanes and bringing it to the countries where they landed. While Title 42 was purported to keep disease out, U.S. immigration regime did the opposite. In the words of the New York Times, making ICE into a global and domestic spreader of the virus. COVID made it abundantly clear, as these physician protesters are insisting that the mass detention of migrants, refugees, and asylum seekers was detrimental to health. And I have a short conclusion, but I wonder if I have time or we should just start Q&A. Okay, great. So thanks. I focused on the systemic endangerment of immigrants' health, but there's really also a flip side to this argument. It's not just that immigrants are not the carriers of disease, but also that immigrants bring a lot of positive health benefits to the US. And this is really what most of my book is about, which I barely touched on today. For example, undocumented people, as you probably have heard, pay more in taxes for things like Medicare and Medicaid than they are able to use themselves because they're not allowed to use it. And this is something that's actually been there's a history of knowing this. We've known this for decades. But it's even more than this in ways ranging from the establishment of immigrant hospitals in the 19th century that expanded health services beyond their communities to immigrants serving in huge numbers as essential health workers today. It's important to note that the argument telling the full truth, they don't bring disease. They're not eating the dogs. They're not eating the cats. We also need to include saying that immigrants are the backbone of the healthcare workforce and also make the US a healthier place for all. And fuller argument appears in my book. I'd like to end with this slide, which shows just a couple weeks ago, a gathering of healthcare workers in New York City who are supporting their Haitian colleagues in the face of the attacks against them. Thank you so much for listening today.
So we do have time for some questions.
Is there a Zoom?
There is.
list?
Check it.
Okay.
This has certainly been a very persuasive argument, but no one has any ideas that you'd like to raise or questions? Oh, yes, right in the back.
Yes, I agree with this is a very argument and laid out very clearly what the issue is. What are the policy solutions at the federal and like state and local levels to address the concerns we discussed today?
Could you repeat the question?
So
Yes.
what are the policies at the state and federal levels that address these concerns? Thank you for the question. So unfortunately, a lot of them exacerbate the concerns by borrowing immigrants from the healthcare that they need. For example, the Affordable Care Act still forbids undocumented people from using it at all. On the state level, there's a lot of variation, and there are some states that are very specifically focusing in on immigrants' exclusion by creating local health plans to cover them. There's such a plan in Illinois. It's kind of like expanded Medicaid, but it's called something else, and California as well, and a few other states. So there's a big gap between the federal and local policies, at least in the case of some states.
So all of this, what would you propose as opposed to what's already occurring?
Medicare for all.
Yes.
I would propose healthcare for everybody who lives in this country. There's really no other solution that will address these health concerns for all. And I also argue in the book that the exclusion of immigrants is part of the exclusion that many American citizens experience because we have a health system that is based on exclusion, not on inclusion. Easier said than done.
Yes, there's a question. Yes.
A lot of it's much healthier than it was. It's not healthy unless you have specific medical care. You can't undergo the immigration process. So that belongs first part of it. But the other thing is, it really is essential in some ways. One is healthcare, but two, our entire agricultural system is highly dependent on it. And California was speaking up in arms when they started making serious efforts through COVID to exclude migrant workers because nobody picked crops.
So can you rephrase those?
I could disagree with both of your comments. So the first point was that immigrants tend to be healthier when they arrive because they have to be generally younger and stronger to make the journey. That's absolutely right. And it's also right what you said about the agricultural system, that there's all these paradoxes and hypocrisies in the system. Some of the same people who are shouting the loudest for exclusion, like in Texas, for example, is a place where business leaders are also pressuring the governor to let people in because they need the workers.
Ah, yes, right next to me.
Thank you for the presentation. You mentioned that the farm worker are dangerous 5 times than other workers in your presentation, and you mentioned that they don't have telecommute. So I'm wondering how might the emergency technology like the telehealth and the mobile health clinic could be leveraged to improve the healthcare access for those immigrant population.
Yeah, thank you. I'm sorry, I need to repeat what you said. The question was about whether technologies like telehealth and mobile health can assist immigrant communities. Absolutely, and that's been true historically, not just now. So the United Farm Workers that I mentioned, they started a mobile trailer clinic for striking agricultural workers in the late 60s. And that idea goes back even further to the migrant health efforts of the federal government in the 1930s. But they need the funding, and they often, like all of these programs that are even around today, like migrant health, are really, really great, but they're hugely underfunded. So the technology and the ideas and the experience is there, but the funding has not been, the support has not been there.
Yes.
I'm wondering if you could say more about if this sort of rhetoric has also come up in relation to, I guess, kind of US imperial subjects. I'm thinking of Puerto Rico, Hawaii, Guam, American Samoa. Is there similar rhetoric about anxiety with disease?
Yeah, sure.
Can you repeat the question?
The question is, has this rhetoric about immigrants being diseased also shown up in discourse on colonial subjects? Absolutely. One of the arguments, this goes back to teaching the U.S. survey. One of the arguments for like why the U.S. should take over those countries in 1898 was that these people can't take care of themselves. They're diseased. They don't have public health in place. So we need to come in and take over their health systems.
Have we looked at all at the question of, Indian populations in the United States? And how have they fared in terms of healthcare?
Yeah, that's not one of my areas of research, but it's certainly a hugely important context for this history that we're talking about.
We had an online question. Can you talk about the Bracero program ending and when Medicaid begins? The programs don't chronologically overlap, but did you find any overlap amongst the policymakers charged with managing migrant health?
Oh my gosh, that is such a great question. So I don't need to repeat it because you read it. So the people were not the same. So the people who pushed for the creation of Medicaid were not, I didn't really find much overlap between those who were pushing for the end of the Bracero program. But the ideas were very similar in that one of the reasons the Bracero program ended, that I kind of discovered this in my book, I'm not sure anybody's made this argument yet, is that employers and the government were worried that because Braceros actually had health insurance, that would force domestic employers to start providing health care for their own domestic farm workers. So it was actually an anti-health measure in some ways to end the Bracero program, because then it ended this idea that farm workers were entitled to any sort of medical care. So Medicaid coming in after that is actually kind of a contradiction to that trajectory. It's kind of a bizarre story.
Yes, I had a question.
Did the presidential candidates currently, did they make any promises regarding the migrant health issues, or what really?
No. Both of the campaigns right now are kind of echoing each other in terms of exclusion and wanting to, close down the border, reduce immigration. I think that the rhetoric is very different and that it's important. I mean, words matter, So the fact that one side is saying that people are bringing disease and eating dogs, the other side is saying immigrants deserve our sympathy. I think that's a start. But I think that in 2016, Hillary Clinton had actually proposed adding undocumented people to the Affordable Care Act. There's no discussion of that this time around. I will say that the Biden administration did recently include DACA recipients, so young dreamers, in the ACA. So there has been a small healthcare expansion toward immigrants under the Biden administration, but haven't heard from Harris anything more about that. Since you brought it up, I was very intrigued to hear about her proposal to cover home health care under Medicare, and that is inseparable from immigration because who are going to be the caregivers? Who are going to be the home health workers? They're already a highly immigrant industry. Thanks for your question. I'm sorry I didn't repeat it. I'm doing a terrible job of that.
Well, this has been really a marvelous, it seems to me, exposition, of what value, again, immigrants bring to the United States, but how often now, they in fact are exploited in the process and are in fact, not the people bringing illnesses, but in fact are the ones who frequently develop them. So we'd like to thank you so much for coming.
you.
We have not offered you very much, but we would like to give you David Rogers Health Policy Colloquium Medallion.
Oh, I need that.
Yes, it's a real. Yes.
Amazing.
Uh-huh.
I'm just sharing my book information. There's a discount code if you want to order it at the bottom for 30% off.
And next week, we will be privileged to have a Brazilian perspective on medical demography and the unified health system, provided by Valerie Aoki, who is a tenured professor in the Department of Dermatology in the University of São Paulo, Brazil. So I hope we'll see you all here then for a description of what's happening in Brazil. Thank you again. Look forward to seeing you.
Dr.